if you go down the combination route, does it matter when you stage, and imagine the majority of us are all probably going to do Y90 in the U.S. as a combination for the local regional approach in combination. Does it matter when you start immunotherapy in relation to the Y90? Because I think it's a question we get often. It's like we'll hear it from other interventionalists, and they'll say, when do I tell our oncologist, when do I have my discussion with our oncologist about when I should do my Y90 in relation to immunotherapy? Should I do it before? Should I do it after the first dose? Should I do it after they've been on it for a while? When's the right time to start Y90 in relation to immunotherapy?
So there are a few studies on the combination, systemic plus Y90, all very small, like 20 plus patients or so, but different study designed it a different way. Some give Y90 a week before systemic immunotherapy. Some give Y90 like 1 to 2 weeks after. From all these like small trials, I don't think it matters how you sequence it. I would say definitely not like the day after Y90, I'm giving them immunotherapy. The liver enzyme is still high at that time. But I think if you space everything out 1 or 2 weeks apart, in my experience, it doesn't matter so that much. But of course, I don't give bevacizumab before Y90.
I agree. I don't think we know from a tumor biology perspective what's best, and the studies that have been done are very small and weren't really powered to ask that question. I think we can comfortably say it's safe, so we all feel comfortable doing that. But, as you all know, it can be challenging for us to know when to introduce immunotherapy in terms of what are we going to monitor, because there's so much inflammatory response after the tear. Imaging is not going to be our best surrogate moving forward for months until things kind of declare themselves. So that also can be a challenge for us as well post-tear. When do we start immunotherapy knowing what we're going to monitor for response?
I think another point, too, is, and we looked at our own data, and we actually found that there was no difference in outcomes or adverse events with when they started immunotherapy to Y90. But I have a dosing-related question for you, Zach, because I imagine you're doing lots of Y90, and I got to get you to talk at this table with these oncology geniuses. Do you dose any differently when you do Y90 in conjunction with combination therapy? Do you have any considerations there? Now, I've heard some approaches, but I want to hear yours.
Yeah, totally. I'll even take a step back, right? So when I look at, we talked about bevacizumab, right? Most of my experience before atezo-bev was FOLFOX bev in colorectal patients, right? And these patients were getting FOLFOX bev for quite a while before I would do, radioembolization, and their arteries were affected by it, right? And it was a huge issue. I have not seen that issue in my HCC patients. And so I wouldn't, for all the interventionalists out there, I wouldn't use that as a reason not to consider intraarterial therapy, is that I just don't see the same thing. And I think our current protocol is just to skip an infusion before, give us a couple weeks, and then they can start it almost immediately after the procedure as well, continuing it back. As far as dosing, it always talks about the same thing that we talked about previously, is what are your intents, right? So if they have a solitary tumor that's growing, which is our most common scenario that we've been treating after immunotherapy, I'm talking about ablative therapy, right? I want this tumor to be gone completely, the one that's growing. And the rest of the tumors inside of the liver presumptively are being controlled by the immunotherapy, right? And so then you're just using straight ablative dosing. If they have multifocal progression throughout the entire liver, I don't think addition of local regional therapy is going to be that helpful. And, maybe not, instead of doing a palliative, amount of dosing, we can start to discuss switching systemic therapies at that point.
And I have a similar approach to you. If you can ablate it, if you can give an ablative dose, ablative dose. I've also seen these patients that have been on immunotherapy that have, when we talked about this in that dosimetry session, where they have disease that's controlled, like they're not non-progressing disease, but not necessarily responding disease. They seem to be in this state where if you flick them hard enough, they're going to die. Like they don't necessarily need a massive ablative dose, but they just need a decent dose to be stimulated to die. And we had a couple guys. We had one guy that was thinking he was headed to hospice, and he had controlled disease. We wound up Y90 in him. He had stable disease, but he was non-progressing, but he wasn't loving immuno. It was under control. We Y90'd him. Now he's back to playing music in Mississippi, which I thought was really cool. I've heard of another approach, too, when dealing with combination Y90 and immunotherapy, is to not necessarily do the same type of ablative dose as you would to basically leave some tumor viable for the immune system to respond. Now, I can tell you, I don't personally do that. I would rather just go in and kill it straight up. What are your thoughts on that?
Yeah, so I don't know if I would necessarily do that just to do it. I understand the complete physiology and reason why you'd want to do it. I think the idea of partial ablation with immunotherapy is very intriguing, and there's some early evidence in melanoma prospectively to show it. I would love to do that as part of a trial, right?
But you wouldn't advocate for someone to do it outside of a trial right now?
Nope. I think if they're having growing disease, you have to treat the entirety of the disease, which is just an oncologic principle, right? Basic oncologic procedures are not, I'm going to take out 2/3 of the tumor and just leave some behind. Right. Until a patient would have, I think in my opinion, a patient should understand the risks of what they're doing before having that done. And a clinical trial is the best way of doing that, where there's a very thorough informed consent.